Michael is president and CEO of Northwell Health, which most of you are aware of. One of the largest in the world, 21 hospitals, $16.5 billion in revenue, 84,000 employees. And I've told him he will get a question about, is big good or bad? So if I don't ask it, you may ask it. He grew up in Limerick, Ireland, went to school, or started his school, just south of there in University of County Cork. He tells me he came to the US, though, because he needed to make some money. He finished at Fordham. But while he was in Ireland, it turns out he was a standout hurling player. Now, you understand, it's not a Dartmouth definition of hurling. This is a game that's played on a field. He was not only a standout, he was a decorated player in the national championship team. This is played on a field with nets on either end, and it's kind of like bats. They're thick like, field hockey sticks, but like lacrosse, so they bat this ball around. Everybody wears masks, but apparently not when Michael was playing hurling. So he finished up his degree at Fordham. Then he taught there, got a master's degree in policy and social services, and then taught in that program. Leadership skills showed themselves early, and he was associate dean by the time he left a couple of years later. And Como was governor, and he moved over to the state, deputy secretary for Health and Human Services, ended up a stint as commissioner for social services for the state of New York, and then did a stint at Empire Blue Cross Blue Shield. 1995, he moved to North Shore Long Island Jewish, Northwell, and I won't trip over that again. What was then North Shore Long Island Jewish, as chief operating officer. By 2002, he was president and CEO, about 3 hospitals, about 15,000 employees. He's a member of the Institute of Medicine. He is an honorary member of the Royal College of Physicians in Ireland. He is co-founder of the Zucker School of Medicine at Hofstra. Former chairman of the board at IHI. He's still on the board, but emeritus. Awards, just numerous awards. A couple I wrote down: the Deming Cup at Columbia Business School, President's Distinguished Service Award for Irish Citizens Working Abroad, Grand Marshal of the New York City St. Patrick's Day Parade, numerous honorary doctorates, including Fordham, Hofstra, Queen's University in Belfast, and others. Modern Healthcare's 2022 #1 most influential person in healthcare. And then I'll conclude just one story that he doesn't know, but just how important he was into this launch of this program, and certainly my career. The year is 2008, and we visited North Shore Long Island Jewish. Larry Smith was your chief medical officer and was soon to be dean of the new School of Medicine. And Smith had invited us down. He knew Dartmouth's work well and thought there might be some educational opportunities. We could put together some programs. So this was an exploratory trip. And we talked to several people and then came back. This was in June, so in September we went down to present what we thought would work, and we were allowed an audience with you. And Larry Smith was far too nice to say this, but in about 3 questions, you figured out it was all vaporware. We had never done anything like this, and we were punching way above our weight. And you didn't exactly say so, but we knew after that meeting we weren't going to get the gig, and we didn't. About 3 months later, Jim Kim at Dartmouth says, hey, I want Tuck School and TDI to put together a program to teach the healthcare leaders of tomorrow. And of course, this wasn't the first time. Susan Dentzer had said the same thing a few years earlier. But then I attended the next meeting. So Jim Weinstein, director of TDI, and Paul Danos, dean of the medical school, got a group of us together, and this is Kim's vision. And I said, oh, wow, I have a curriculum that might work for that. And they said, oh my God, that's what we need. So because you said no, if you had said yes, we'd have been way too busy working on that and wouldn't have been able to put time into this. And I certainly wouldn't have been able to help lead the program at the beginning. So I thank you. That's, I told you I would ask you this question, and I think it's really important, and a lot of good answers has come out at the dinner table. But we just heard Sachin Jain, who is highly respected in the industry, tell us that part of the problem with healthcare is these systems just keep bulking up and there's no longer any competition. It screws up the reimbursement system and it depersonalizes healthcare. And everybody in the room would be delighted to hear your response to that.
Well, I know Sachin Jain pretty well. We've had discussions over the years. And it's dangerous to lump all health systems as one. If you see one health system, you see one health system. They're all different. Even in New York, there are no two that are exactly the same. I would argue that they're very opposite to Sachin. If you do it right, and your mission is focused for the right reasons, having a large integrated system with all the major components that you need to manage the continuum of care can only be done effectively in a large health system. So, for example, in our health system, everybody looks at us, sometimes people look at us and they think, well, you have hospitals. Well, we have 21 hospitals, but about half of those hospitals would probably not exist today if we had not taken them over and turned them around, because they were all losing money. They were all in very, very bad shape. If they had been left alone, they would not exist. And those communities that they exist in would be without any health care because there was nobody to take up the slack. We today have, while we have 21 hospitals, we have 900, almost 900 outpatient ambulatory facilities. These are all relatively small entities in communities where healthcare was not in existence before. And we also have a full continuum of post-acute, home care, everything else, plus research, academics, all of that. That is not possible unless you have the ability to be able to work it through scale, have large anchor places to be able to fund other places that are in very, very poor shape and be able to expand. So we're not just a hospital system. People who will talk about this will think of us as just hospitals, but only 46% of Northwell's business is today hospital business. 46%. The rest of it is non-hospital. I have the largest primary care network of services in New York. I have the largest ambulatory set of services in New York. I have the largest post-acute in New York. That's the benefit you can get if, in my view, you do it right. There are others who don't do it that way. So there are other health systems in many parts of the country that are all focused on bringing everything into the center and building up the central hospital network without dispersing the care out into the community. And if you do that, then you could argue that Sachin, in those circumstances, might be right. But when it comes to entities like the one we have and others, I think he's wrong. And Sachin and I have had this discussion. You've got to look at this from a very practical point of view and understand what you're talking about rather than being just academic about it. Because a lot of people who make the arguments about things don't exactly know what happens. And our biggest investment is in home care, it's in ambulatory care, outpatients, serving poor communities, developing a broad distribution of services in communities that prior didn't have them, and saving hospitals that without us would not exist and care would not be existing in those communities. So I feel very proud about what health systems like us have done. And one last point. In the middle of COVID, if you did not have an integrated system to be able to manage the continuum of care across, you were in big trouble. It would not have been able to be handled by single individual hospitals just alone. We saw 450,000 COVID patients. And I was able to move it across the full continuum. And the COVID, to me, demonstrated the benefits of health systems when it is done the right way. And I'm not suggesting we're perfect. I'm not suggesting we have done everything perfectly. Nobody ever does. But I would say that you've got to look at the positives and not just only think of health systems as being hospital-focused. And those who do that kind of work are moving in the wrong direction. If they do the opposite and look at the full continuum, they're moving in the right direction.
Thank you. So you're obviously a successful leader. Tell us a little bit about your leadership style and how it developed. What in your background led you to the leader you are?
Well, we're all influenced by our background. I mean, we're shaped by our background. And on the work side of my background, I benefited from working as a longshoreman, working in construction. I worked as a plumber. I did that for years and years and years. I worked in steel factories in England when I was 16 years old. That shapes you. I've been in the academic world. I've been in the insurance world. I've been in the government world for 12 years. I've been in the provider world. That shapes you. I also grew up in extreme poverty, where we didn't have electricity, running water, bathrooms, heat, or anything. That shapes you. I understand what it's like to be down here. I appreciate the concerns and the issues that people that don't have many of the material benefits that we all take for granted. I was there. I understand. I think all of that shapes your leadership style. I think I'm pretty participatory. I'm a big believer in having an ethic where you're focused on doing the right thing all the time, where you're here for the benefit of the people out in the community, and your goal is to make their lives better, not just only on the medical side, but on the upstream side of the business, all the prevention, wellness, all of the things that we're involved in. And I believe that very, very strongly that you enhance the ability of all your employees to grow to their maximum potential. So we invest heavily in employee talent management. I believe very strongly in communication. I believe very, very strongly in communication with employees. I believe very, very strongly in making sure that we eliminate those negative behaviors that prevent the development of a trusting relationship among employees and between employees and the customer/patient. This is why, for example, every Monday morning I meet with all new employees that join the health system. We hire about 300 people a week, between 250 and 300 people a week, and I meet them all. I spend a number of hours with them all every single Monday morning. Yesterday, I did my 15th town hall. I have another one tomorrow. Communication, communication, communication. Walking the floors. Talking to the people at all levels of the organization. Not being too concerned about your title. Not being convinced that you got to stay in your office, but get out. The people who make the system work are the people on the front lines who do the work. I don't do the work. They do the work. The person who sweeps the floor on an ambulatory site or in a hospital is a quality worker, because if they don't do it right, I have an infection. The security guard is important. The dietary technician is important. Nurses and doctors, obviously, yes. So culture is important. We're in the trust business with one another and with the people we serve. We've got to be customer focused and customer addicted. You've got to look at the world from the outside in, not the inside out. And that's the kind of stuff that drives me. That's what gets me excited. My best days are when I'm out with employees. On Tuesday night, I took 30 employees out to dinner. I do it every month. I take 30 frontline employees to dinner every month. From various facilities, outpatient, ambulatory home, tertiary, community hospital, etc. Bring them together. enhance communication, cross-fertilize. Your greatest asset that you have in any organization are the people that come in the morning and leave in the afternoon. That's your core asset. It's not the buildings, it's not just the technology, that gets an awful lot of attention. Those are important, but your greatest asset are the people. And if you take care of the people in the organization the right way, to the best of your ability, and make it comfortable for them to do their best work, they take better care of the customers who come in. In many ways, it's very simple. It's not overly complicated. You deal with people the way you would want to be dealt with yourself. And by the way, one last point. Then you bring around you the people with the same positive attitude, the same sense of mission, the same sense of commitment, the same sense of dedication, and you hire for attitude. I could care less where you went to college. I could care less about your grade point average. I could care less whether it was an Ivy League school or not. I don't think it matters a whit. It matters what you do, how you care, what you believe. That's what matters. You hire those people. I have some of them in the room here. Many of them are in your program. And so I'm privileged to work with people like that. And you bring a number of people like that around you, and you make sure that you eliminate the behaviors that are negative. Culture is about the personality of the organization. How do we work together? And how do we operate? You eliminate the people, and you eliminate the behaviors that are not part of a positive, optimistic, futuristic culture. And we've done that. All of the leadership in my health system today are all new. When I started, none of the people who were with me when I started are around today. It's like weeding a garden. You want the good vegetables to grow, get rid of the weeds.
So has this, so we've had all these workforce problems and resignations and burnout and people leaving. Are you seeing something different at Northwell?
Well, everything has changed a little bit. Remember, people talk about the Great Resignation, but the labor force participation has been decreasing, especially for males, since the 1970s. It's been a continuing slow decline. It has accelerated a little bit in the last number of years, but there's not been this massive Great Resignation since COVID. There's been a continuous drop in labor force participation, especially among males. You can argue why. But the thing that today that is different, that the relationship between employees and employers is a little bit different today because COVID changed us all. I don't think any of us are exactly the same today as we were prior to COVID, especially if you were out in the world treating COVID patients during that period of time. Today we have more remote work. There is more people who want to work a little bit less. I want a different kind of an environment. I want a better life-work balance, which is very, very hard, by the way. People forget this, but it's very hard to have an appropriate work-life balance with the massive addiction to technology. There was a time not long ago when you could go home and not have to be on email all night. Today, we talk about technology being a benefit, which it is, but there is another downside to this, which I think is pretty negative, which we've got to talk about at some point. So it has changed, but we have about, 6,000, 7,000 people working remote, but most of it is becoming hybrid. I don't think we will know for a couple of years how we will settle down. So we have remodeled many of our offices so people can come in part-time. So 2 days at home, 3 days inside, 3 days at home, 2 days at work. That will all settle itself down, and that is the new world. Because of technology, location matters less today in certain businesses and for certain functions. But in the core business of healthcare, you've got to come to work. If I was JP Morgan, 100% of my employees can work remote. But if I'm running a hospital, you've got to come to work. You can't take care of patients in an operating room remote. There are certain remote things you can do, but you can't do it. So in many ways, we're fortunate being in healthcare because for the bulk of our employees, you've got to be on site. So we have a benefit to that as distinct from a Goldman Sachs or a JP Morgan, for example. So it's a different relationship, but it's like everything else in life. Things change. things get modified. You're defined by not what happens to you in life, you're defined by how you react to it. So my attitude is stop whining about it, stop complaining about it, adapt to it. Move it in the right direction. Stop writing arguments how bad it is. It is what it is. Figure out how to turn it into a positive.
So talk to us a little bit more about innovation, what Northwell does to stay abreast and contributing to pushing that horizon, and then particularly, because I think it applies so well, how do you get the best ideas to spread across an organization of that magnitude?
Well, innovation is not a project. It's not a separate thing. It's an inbuilt part of your DNA. I mean, you should be thinking innovation every day, all the time. Because what is it? It's about doing a little bit something different tomorrow than I did yesterday. That's the essence of innovation. If you come to work every day to repeat what you did yesterday, there's something wrong with you. If you get up every morning and say, I'm going to do what I did last week, again, and the next week I'll do what I did last week, there's something wrong with you. You've got to change what you did. That, to me, is the essence of innovation. You bring around you, you hire the right kind of leadership, because the people you bring into the organization at every level, and I talk about this at orientation when I do it to all new employees, I talk about the innovation culture that we have, where people got to be thinking differently about everything. If you're working in the laundry, ask yourself, how should I do it differently than we did it last year? Or you're working in the food service. Our food service is run by Michelin star chefs. My chief chef was the chief chef at the Plaza Hotel. It totally changed the whole way we deliver food. And we deliver, by the way, we run a huge restaurant business. We deliver 10 million meals a year. Just think of that. We're in the food business. This is another issue to think about, by the way, and I tell, big health systems are candy stores of opportunity. You want to be in the food business? We're one of the biggest food businesses. You want to be real estate business? We got one of the biggest real estate businesses. You want to be in IT? We got a huge IT business. You want to be in finance? We got a finance business. You want to be in the laundry business? We're in the laundry business, right? You want to be in the car maintenance business? We got it. You want to be in the carpenter business? We got it. What do we have? What do you want? There is nothing you could want that we don't have in some regard. This goes back to the whole culture of innovation, getting people to show them the possibilities. We also, if you have a good idea in one part of an organization, that we do all the time, you move it across the organization where it makes sense. And innovation comes from all directions. It doesn't come from the top down always, necessarily. It comes from the bottom up. It comes from the left side to the right side. It comes from the community hospital to the tertiary and vice versa. And we also have, and we actually have it coming up in about 2 weeks, we have an innovation challenge every year. And we send out a request across the whole health system, all employees, asking them to come up with ideas, new innovative ideas, that could potentially become a new way of doing business or a new business itself. And we have a major competition. We have an outside external group of people that makes the final decisions. And those that get selected, which will happen in about 2 weeks, we invest money into that idea. Last year, a couple of ideas went. I'll commit $500,000. When somebody comes up with the best idea that wins in 2 weeks, I will commit to each of those ideas $500,000 to take the idea and sprout it. It's unbelievably competitive. So if you walk around the organization continuously and you say to people, think anew, think differently, don't be comfortable. I tell people you should always be a little bit unhappy. Because unhappy people do something to improve their condition. If you're completely satisfied with your condition, you won't innovate a damn thing. I'm sure everybody here would like to be in a little bit of a different place because you are all a little bit unhappy in your current circumstance. It's another way to think about it. If you're totally comfortable, why change? So you want to create that positive energy. And that's what we try to do across the organization. And I walk the floors all the time. I'm out in the facilities all the time. During COVID, I was in every COVID unit. I was in a COVID unit every single day. And by the way, I got to say this, the amount, the compassion and the dedication and the expertise that you observe in circumstances like that is something that is absolutely extraordinary. Now, when people criticize healthcare inappropriately, they never were around to see what happened in the height of a crisis like COVID. And lastly, I allowed a documentary crew into one of my big tertiary hospitals during COVID for 5 months. They filmed everything inside that hospital. They filmed 850 hours of film. It was turned into a documentary called First Wave, which you should all watch. It gives you a view into what happened. It's on Netflix. It was the #1 show on Netflix. It won 3 Emmys. It's an extraordinary show because most of the world didn't know what happened on the inside during COVID. Didn't know what the people on the floors did every day, the innovation during COVID. COVID was an experiment in innovation at every level. It's hard not to be inspired, extraordinarily positive, when you observe what staff at every level did and the integration of how they work together, the interdisciplinary nature of how they work together, absolutely extraordinary. So I get annoyed when people say, oh, healthcare is this and healthcare is that. You've not been there. You're not there each and every day seeing what happens. Sure, there are things that are wrong. Like in every business and every endeavor, there are things that are wrong. There's a lot more right than there is wrong.
So it's not surprising that you won the Deming Award. For me, Deming said there will never be a vice president of innovation or quality, because that means it's somebody else's job.
It's everybody's job.
Everybody shows up thinking that way. It's fascinating that we ended up in laundry talking about innovation. Yeah. Thank you.
A lot of some of my staff are spread out along here. I mean, they're innovators. They come up with ideas every day.
So when we think about innovation, though, in healthcare, we immediately jump to IT, and we immediately think of the dehumanizing effect of what we've done to ourselves over the last decade. How has Northwell dealt with that? How do we avoid the dehumanization of healthcare with all the tools we have to satisfy?
By emphasizing the personal contact nature of the care. That technology should never should never become a substitute for the person-to-person relationship and contact. It's a tool that can be an additive, but it should never substitute for. And I talk about that with employees every Monday when I do orientation. It's like anything. It's like a carpenter's tool, and and there are great benefits to it. We are very involved in the AI side of the business. We have AI companies. We've started AI companies, and AI has been around for quite a while. But we've got to be careful as we go forward that there are very positive aspects to this, but there are also very negative aspects potentially. But you cannot substitute for the human element. Any one of us goes to any one of the facilities to get care, we want to have somebody to talk to us, to sit next to us, to relate to us. That doesn't mean there are not functions that can be done digitally, but it can only be that. So you emphasize the combination of the two all the time. There will be increasing, telemedicine, digital health. There will be a whole component of care that will be in that side of it. But when something serious happens and you actually need to go and have a procedure or sit and meet with the physician, it has to be person to person. And we can't lose that, otherwise we will lose something very, very special.
But does Northwell do anything for the clinicians who are feeling this strong tug? These are all the questions you've got to answer, and if you decide to take exception with the recommendation from Epic or whatever, you need to tell me why. And I want you to pay attention to the patient. They want to as well.
Well, one of the things that has to happen is that if you want to be innovative and you want to enhance the person-to-person, patient, caregiver relationship. We have to take a major hatchet to a lot of the regulatory organizations that regulate us. We are unbelievably over-regulated, micro-regulated. If you have a nurse on the floor that has to spend about 50% of their time in documenting stuff that makes very little difference to anything, right? We add, and add. The reason we were able to do extraordinary in person-to-person work during COVID was most of the regulations were dispensed with. Compliance and regulation is the antithesis of innovation and creativity and burnout. Why are people burned out? It's the constant paperwork, the unnecessary paperwork, the quality criteria that you're document, sign off, check. I'm not against appropriate regulation, but we've got to take a look at it and say, if there's 100 things out there, 20 of them might be very, very relevant, but the rest, the other 8 of them, have got to be get rid of it. We never get rid of it. It's like somebody said once time, we're governed by dead people. They write regulations and regulations. They never get rid of anything. I mean, if you look at we have a whole quality operation in most of our facilities, and I guarantee you, if you sit down with practitioners on the ground, they'll tell you that a large share of all of those things have very little to do with the actual quality of care that we have to deliver.
So you don't have almost anybody in this room who's disagreeing with that.
Right.
Do you have advice for them? How can they take a stand? What can they do to push back? What's the path forward?
What I'm doing right now inside the organization is I have a large group of people in the organization. What I say, identify for me the stupid, and then I want to launch a health campaign to get rid of the stupid, to allow people to have more freedom to do what's appropriate and get rid of that which is inappropriate. And I think if we get a collection of health systems and hospitals and others identifying a core group of things that we all agree on that contributes nothing to the production of a better product for the patient, and we lobby to get rid of some of those things, both from the Joint Commission, which are with us right now, by the way. We had the Joint Commission in our hospitals right now. They're with us for 2 years because we're so large. They come in, they never leave. All right? And, tomorrow morning, I have a meeting with the Joint Commission when I go back. I'll give you an example. Years ago, the Joint Commission had this whole criteria about what you need to document about the characteristics of each of your staff. They had the whole personnel file. And it was the stupidest thing in the world. And now we had a Joint Commission. I stood up, I was sitting in the back of the room as I was making the presentation. I walked to the front of the room and I basically said, we're not doing this anymore. This is ridiculously stupid because it was built at a time it's archaic. I said, we're going to come up with a whole new series of recommendations on how you should evaluate the caliber of the individual staff in our facilities. And we're going to go to you with our recommendations and we'll work with you to come up with a whole new design. I remember at that time the staff in the room almost fell off because I figured the Joint Commission would kill us, but they didn't. They actually adapted their policies based upon the proposals we made as a subsequent to that meeting. I think we got to do more of this. And I think it has to be a collective of organizations, though. But don't get me wrong, I'm not against regulation. I'm against stupid stuff that doesn't contribute to anything. So let's identify the stupid, develop a coalition of people around that so that we can go to the Joint Commission, the CMS, and the state agencies to say, why? Why do I have to do this? Tell me what benefit this has to the outcome that we want to deliver for patients at the end of the day.
So you have several people in this room. If you want to provide a focal point, somebody for them to email, they're glad to give you suggestions for stupid and join the coalition.
Absolutely. Kevin Biner, stand up, Kevin. You see Kevin? He'll take all the stupid ideas from you. Kevin is one of my regional directors. Why, we talk about this. Take a look at the quality oversight, the bureaucracies we've built up in every hospital on quality metrics, and tell me how much of it actually contributes to quality.
I promise you, you don't need to convince them. But they don't feel like they have a voice. And you're saying, look, you have a voice.
You have a voice. Stand up and be counted.
Okay.
You know, you get people, you know, but you got to be practical about it. You can't be just so goddamn, I may be a little bit generic in my discussions here for effect, but you got to be practical about it. You got to really identify the things that just any logical person would say, this doesn't make any sense. And there are enough of them around there, and you get rid of them and you start the campaign. Because there is a push on the other side to just load on more and more and more. And I think the industry needs to push back for productive reasons, not to be a pain in the butt, but for productive reasons, for the benefit of the patients that we now serve, so that we can spend more time with the patient doing what's right, not spending a lot of time filling out forms that have no contribution.
So you make this look easy.
It is.
So, but no, I'm drawing back a little bit, just looking at the whole journey as running an organization this large. So there had to be major obstacles where you went home at night and said, oh my God, what's going to happen now? Talk to us about some difficulties that you took the organization through and how you and they survived it.
Well, I mean, my staff knows I say this all the time. I don't ever look at anything as a challenge. Everything you look at is an opportunity. As Thoreau once has said, you know, it's not what you look at that matters, it's what you see. If I look at something and I see a challenge, my whole perspective is one way. If I look at it and I see an opportunity, my perspective is very, very different. So to give you a couple of examples, I've gone through 21 mergers, hospital mergers. None of those are easy. You just got to understand how to appropriately go manage it, deal with the personalities, deal with the politics. Remember, every organization is a multiplicity of constituencies. So the politics is involved with every little piece of it. So you got to be able to understand who are your influencers, who are your informal leaders, not the people with the titles necessarily, but who are your informal leaders, who are the people when they speak, somebody else, another person listens. Identify them. So you go through the mergers. Some of them take years. It's a lot easier to go slow at the beginning so you can go fast at the end. People like to say, when people come into me and I have somebody new from the outside, let's say, or a physician or a leader, they always come into the office and say, what do you want me to do right away? What is the deliverable in the next 6 to 12 months? And my answer is nothing. I don't want you to do anything except one thing. Learn the organization. Understand the people, understand the culture, learn who the influencers are, learn who you should be listening to. Don't come in, think, and then now when you get that, you can figure it out. So a lot of the mergers, they were difficult, but none of it was insurmountable. We've managed it all, and we're a completely integrated system. The frustration thing, if you talk about something that frustrated me, I started an insurance company because I'm a big believer that you've got to control over the financial side of the organization as well as the delivery side. And most big organizations like Kaiser, Permanente, Intermountain, you know, they have an insurance company. They have the ability to be able to do real value care, however you define that. There's no two people who will agree on the definition actually, but you have a much better opportunity to define it differently. I started an insurance company, and but I had to get rid of it because of governmental regulation on the risk adjuster that made no sense. Where my biggest competitor in New York was United. They were in the business for 12 years. I just started. They assumed that since I just started, I had all healthy people. Remember, when you start an insurance company, the people who sign up at the beginning are healthy. If they're with you for a long time, they get sick. So all of a sudden, I ended up with this stupid regulation. that I had to pay 40 cents of every premium dollar that I collected to United Health. Talk about reverse Robin Hood. United Health made $26 billion last year. We had to shut the program down. Was that a frustration? Yes. So we're now coming at it another way. That was a wonderful example of a complete lack of understanding by the people from the regulatory side of the business. This was the federal level at that time, members of Congress, who didn't understand and who killed a great program. We were expanding. We had a 98% customer satisfaction, and I had to get out of the business. All for the wrong reason. That was a real frustration. So what I've now done is I've started a company called Northwell Direct, and I'm going directly to employers to contract directly with employers and bypassing the middleman. Because at the end of the day, you have to have the payment side and the money, and as much as we possibly can, get rid of the middleman. I try to do, in a lot of our initiatives, to get rid of the person in the middle. So you go directly to the source, and you get control of the financial arrangements so that you can manage the care the way you want to manage it, and not have to go through pre-authorization, all of that garbage we got to go through every single day with payers and everybody else. That was a frustration. But you move on. We're now coming at it another way. So we'll be back in that business in the future, but in a different way.
Watch out, United.
Listen, we work with United, but there is something wrong when you have a large health systems like us that run on 1.5–2% margins, and you have an insurance company that makes $28 billion a year. There's something wrong. We get the criticism, they don't. Is there something right about that? They make medical decisions without any liability. They tell us that they're not going to pay for this, not going to pay for that. You can't do the care in the hospital. You got to do it in an ambulatory site. They never see the patient. They make decisions, and they will tell you right in front of you, we have the right to make medical decisions. And I say, if that's what you want to do, take the liability too. If bad things happen, you're liable. Bad things happen in our system, I'm liable. You have no liability. You want to talk about having your cake and eat it? Yeah, I work with United. They do great for their side of the business, right? You look at the companies that do very well on Wall Street. I mean, insurance companies do quite well, and they're in. Now this is another thing. Well, I'm on the run here. All of these entities. I'm all for competition. I love competition. I'm very competitive. Like when I played sports, I love competition. You do your best when you're up against the best. But don't have CVS and others tell me that they're going to transform healthcare. They're ankle biters. They take the small little stuff that is the healthy stuff, and they pick off a little piece and pick off a little piece. God forbid they would take care of anybody that's really sick or anybody that is anything serious. So compete with me, but I'm in that business too. They open up urgent care. I open up across the street because I'm going to beat them in the urgent care. That's what we got to do. I'm not going to let them take that level of business. I don't know. What, did you ask me a question about this, or did I just go off on a tangent?
I do want to ask you another question because I think the answer is fascinating, and I saw you light up at the table. The medical school you guys launched. Talk to us about it. What the difference in design is.
Well, let me mention a generic concept here, and this goes to education in general. I think education needs a complete overhaul across the board. You can't deliver a different product 20 years from now unless you change the way you educate today to prepare for the delivery of a different project in the future. And that's, I know, what you're doing in your leadership training programs here, etc. So if you want a different kind of physician for the future, you've got to change the way you train today. The whole idea of medical schools from back 15 years, 16 years ago, when they lifted the moratorium to no medical schools, we decided to jump in and do a medical school. And you ask yourself the question, is it appropriate that medical students spend, generically speaking, across about 2 years in a classroom, and then they go into a tertiary campus to do their clinical. You think about that for a second. Most care is not delivered in a tertiary campus. Where's most care delivered? Ambulatory, outpatient, home, hospital at home, et cetera, et cetera. So we decided to build a completely different curriculum. So all our medical students, and our medical school is phenomenally successful, all our medical students are trained as EMTs in the first 9 weeks. When they have that white coat ceremony, they get an EMT license. From day one, they ride the ambulances. We have the largest ambulance network, ground transport network on the East Coast. They're on our ambulances. They're out in people's homes. They're seeing patients from day one. They go pick up a patient, the patient goes to the hospital, they go to the hospital with the patient. They are assigned an OB specialist, a surgery specialist, a behavioral health specialist, an internal medicine doc, and they're out in the field in the practice of medicine from day one. It's 4 years of clinical. We have no lectures, no multiple choice exams. It's all small group learning, and it's using simulation. So every 12 weeks, they go into a simulation. We have a huge simulation training center. They go into that center. There are scenarios given. They have to demonstrate that they know how to do things. Not that they know about things, but that they actually do it, and they're observed. Everybody said to us that they wouldn't pass the boards. They'd blow it out of the water. They wouldn't do good in the national exams, that they wouldn't match well. We have a phenomenal match. Our match was a couple of weeks ago. We matched in all the top places in the country. It took courageous individuals to come into a medical school that was doing something completely different for the first time. We got 6,000 applications the first year. Completely different experience. We have had almost every medical school in the United States come and visit, from Harvard to Yale. We were the advisors. I was one of the lead advisors to Kaiser Permanente when they were deciding to do their medical school. And our nursing school, we have a graduate nursing school, an undergraduate nursing school, a doctoral school. Their model is the same. We have no separate individual departments in the medical school. We have one department of medical education, interdisciplinary. Totally different. Now, that was 15 years ago. This year, we're going through a whole review of the curriculum to see, based upon what we've learned, how do we modify it and adapt it to what may be necessary going forward with all of the changes that are going on. And I'm a big believer in the apprenticeship model. You learn by doing. I worked as a plumber. I could read all the books in plumbing about how to put in a sink. But I know one thing. You don't know anything about how to put in a sink until you put in a sink. Because the book, you ever get when your kids have toys, that you get toys for your kids, and you have the directions? You sit there and you think, who's the stupid person who wrote these stupid directions? Because it bears no relationship to the thing in front of me. Right? Apprenticeship models. May old-fashioned sound, but so we got to rethink everything. You got to be placing kids out into businesses so that they observe, they see, they learn. And you got to indoctrinate them into the world of work much earlier on. And we're doing that. We're very involved with kids. We've got thousands of kids working with us from high schools. We're very, very involved with, we've adopted lots of high schools. We're going to have a presence in every high school in downstate New York. We have scholarship programs for kids from high schools. And we work with 11th and 12th graders, and we bring them into the facilities. They want to know what an MRI looks like. We explain what an MRI looks like. They want to know what an operating room looks like. We bring them in. We open up the horizon of opportunity for them when they're looking at where they want to go into their careers. That's the future workforce, by the way. On another issue, that's the future workforce. We have a pipeline program for our medical schools from poor, underserved areas. And we work with them for years. Every summer, we have internship programs. Right now, we have a couple of thousand students in mentorship and internship programs. But I'm not going out to give them a class. We're bringing them in to see what we do. changes the whole perspective.
So I have one more question, but let's pause and give these guys a chance to ask some questions. I'm guessing you may have hit a few nerves.
If I haven't, I have failed. The whole idea is to just constantly think differently. This is what we try to do in our organization. Just disrupt a little bit. Disrupt yourself before somebody else disrupts you. Think differently, and don't ever, I kept telling staff all the time, don't ever let your current, especially younger people, don't ever let your current circumstance limit your future potential. Everything is possible. It's a lot better to aim high and miss it than to aim low and achieve it.
Questions?
Susan.
So, Michael, we're back in a discussion, as we always are, in healthcare over the cost of healthcare.
Yeah.
What is your recipe for dealing with the cost of healthcare? It's not movement value.
You will never dramatically change the cost of healthcare unless you go upstream. The cost starts upstream. Obesity starts upstream. Food insecurity starts upstream. The leading cause of death for kids, guns, starts upstream. That's why we're very involved in the gun violence issue. We got to put a lot more emphasis upstream. Now, we got to do the downstream well, and that will always be expensive, because especially with the demographics, especially with the phenomenal growth of aging and chronic illness, which, by the way, another way to look at all of that is that we have a very expensive end-of-life healthcare system because because of the advances in science over the last 50 years, we have added about 30 to 40 years to life. Aging is the result of success of healthcare, the advances. That is a given because we all want to live a bit longer. And the biggest expense in healthcare is the last year or two of life. That will continue to be expensive. But if you want over the long haul to change the dynamic, we got to go upstream. And I believe, if you ask me how I would define success in our health system, it would be that I have to be as good on the upstream side, prevention and wellness, just as equally good there as I am on the downstream. We deliver care on the downstream pretty well. Now, you can always have some inefficiencies here and there, you know that. But we're on the upstream side of it. When I have to double the size of seats in my children's hospital to accommodate obese children, I didn't create obese children. I respond to what was created elsewhere. So it's a whole different move to the other side of the equation, which most healthcare organizations have not really done. We can't do it all ourselves. We got to be the catalyst to get everybody to do it. So, see, I define health broadly. We're mostly, if we're honest with ourselves, we're in the medical care delivery business. We're not in the full healthcare business. This is why I took on the gun violence issue as a health issue. That, to me, is a public health issue. The leading cause of death for kids is guns. That's a public health issue. That's why I now have a council of 53 CEOs from around the country involved in this. So, Susan, it's moving up. We spend a lot of time on how do I be more efficient with chronic illness at the end, and we can be more efficient, and we can do it better. And, in certain areas it's more costly than others. It's more costly in New York with a heavily unionized environment. That adds cost. That doesn't mean you're against unions, but it adds cost, let's be honest. But we got to go upstream. Education, food, what schools do with regard to education around health issues is important. If we don't get handled there and we stay downstream, you never change it.
Related to that, how do you justify, right, when you're going upstream, so I'm a CPA, right? So when you go upstream, there's a cost to going upstream.
Yes.
And you need to continue to do the downstream at the same time. And potentially that takes an entire generation before you make that.
It's long term. It's long term.
So how do you make that sale, also having been in government, how do you make that sale to government to say you need to spend more for
Government will never make that decision for you. they won't go there. I tried, and I worked in government for 12 years. Like, I believe government does great work. Don't get me wrong. I was there. I was involved in a lot of good stuff, I think. I went to government in New York State many years ago that I would take responsibility for the whole Medicaid population in the whole geography. And I will take responsibility for their health, not just their medical care delivery, their health. But I want you to give me a 5 to 7 year contract. Pay me what you're spending today and give me a small escalator each year for the next couple of years. And let's agree together to have a mutual agreement on an outcome. And then get out of my way. Get the hell out of my way and let me do it. The problem is they can't figure out how to do multi-year transactions with you. I can't do it for 1 year because it takes you 1 year to assess the problem. Because they go on annualized budgets. And it's so politicized, they couldn't do it. We had this discussion in our organization with some of my people a couple of weeks ago to see if we wanted to go back and try again. So I think I don't sit around waiting for government to help me figure out how to do these things. I'll take advantage of them. I'll work with them. I'll be an innovator for them. But I'm going to try to drive as much as I can myself. Otherwise, I just wait around in frustration. Won't happen. Especially in today's political environment. I would never go work in government today. Susan probably appreciates this. I was in government when I was on the Democratic government side. I would fight with the Republicans, but at nighttime we went out to have dinner and we cut deals. We never made it personal. We didn't live in a toxic world of rage and outrage all the time. We agreed to disagree, but then sit down and work it out. That doesn't happen today. It doesn't happen in Washington, and it doesn't happen in Albany. They don't work together anymore. Nobody sits across the table and have a conscious discussion about, or a practical discussion about how to get anything done. Think about our kids who look at the leadership that we have these days and ask yourself what they think about it. Where negativity is enhanced, compromise is a bad word, discussion is negative. You can't, for the God, you forget it if you change your mind on something. Social media has been a disaster in this regard. So I don't wait around for government to solve these kinds of issues. Government has a big, I'm just knowing New York State, which I know the best, government is a big problem at the moment because most hospitals, using hospitals now, most hospitals in New York State are losing money. There's only a couple of us that are not. And government will continue to badger you about inequity when government, through its reimbursement system, institutionalizes inequity. Because the Medicaid, if you're running a program in New York State and your whole financing is Medicaid, you can't make it. If in more Medicaid in New York State, I got a 1% increase total over the last 15 years. I have a labor force with 4% increases pushed by government every year, including this year, where we had the governor on the street with the union lobbying for 7% salary increases on an annualized basis. And I get a 1% on Medicaid. But they fail to connect the right side with the left side. They forget to connect the two dots. And I'm very compassionate, and I'm the second largest Medicaid provider in New York State. I'm the second largest Medicaid provider. But the only way I can do it is to expand my commercial business as much as I possibly can to be able to pay for Medicaid. And everybody that is 60% plus in Medicaid in New York, one hospital that we're working with is losing $400 million net operating on an annualized basis right now. And the state comes to me and says, take over that hospital. I take over that hospital, it's diluted to my system. I become like them if I take over that hospital that size. And I've taken over many hospitals in bad condition, but this one is a very, very large one. New York State is a huge problem there. There is a huge payment problem because there's no relationship to the expense side of the equation. And you can talk about all the efficiencies in the world, how you can do things a little bit better, how you can ratchet this down, ratchet that down. These are little peanut resolutions compared to the size of the big problem. You can't efficiency your way out of a hospital that's 80% Medicaid, losing $300 million a year and growing, with a labor force that gets guaranteed 5 to 7% annual increases in salary. Illogical. There needs to be an element of common sense that gets back into the equation. And a lot of people on the outside of the world who like to, throw bombs don't understand the fundamental economics of any of this. Some of us, because we have a large distribution network, where I make sure that I get a high slice of the commercial business. That's what all the competition is, by the way, on the commercial business. Right? From both the technology companies, the United Healths of the world, the Optums of the world. That's where they're all going on the commercial side. None of them going on the other side of the equation. None of them going into the Medicaid business in any way. None of them are taking on the biggest problem we're facing these days, which is mental health, behavioral health, which I think is one of the biggest problems we're facing. It's like this. And we are the second largest behavioral health provider in New York State. But you lose money on everything you do there. On every single thing you do in behavioral health, you lose money. So there needs to be more of a realistic discussion of these things. Complicated. Anyway, I'm not whining. I'm going to do what I have to do. I'm just saying that there's a lack of reality in most people's analysis of what's going on the field. It's like, you're a hospital, you're a bad guy. Well, I'm not a hospital business. I'm an ambulatory care, home care business. And I have hospitals. But I'm not just a hospital business. I've done more ambulatory expansions than anybody else. Yet people won't even sometimes acknowledge that. Okay.
I'll take another question.
What time is it, 10 o'clock?
No, we'll get you out of here soon.
No, I'm fine. I'm good.
Hi, this was one of the best talks I've ever heard. So, my name is Maria. I'm a medical doctor. I'm an MD and a student in the Master in Public Health program at TDI and a leadership and preventive medicine resident. So, along with my colleagues here. So, I feel ashamed to ask you this after you was just told us. And so, I have two questions for you. You spoke about innovation, which is admirable. My question is about how the human brain will be able to keep up with all the innovation. A lot of physicians, including myself, cannot keep up. And this is contributing to our burnout. Like even the fact when we open Epic and each month or so it changed the interface, it just bothers us and hinder our work. And I'm not complaining. Data obesity and the multitasking that we have to do in our everyday job is taking away from the time we have with our patients.
Right.
And I understand that on the other side of leadership, there's a lot of constraints you just spoke about. The second thing is, and these are very connected. I did a project on hiring scribes for physicians at Dartmouth, and the ROI on at least I've watched this system outside in dermatology at Dartmouth actually, and it worked. And the project was shut down completely, though there are studies about increased revenue, increased patient and physician satisfactions. So from your experience, why is this not being implemented in healthcare systems? Thank you.
Well, if I get your question, I mean, you've got to provide a lot. First of all, goes back to something I said. You got to get rid of some of the stuff that doesn't contribute to anybody's benefit here. A lot of the stuff that you're required to do on a continuing basis. And on Epic, we are going through a transition to Epic over the next couple of years. We were Allscripts. We are moving into Epic. That's $1 billion cost for us to transition into Epic across the board. That's going to bring, everybody's happy that we're doing it, but it's going to bring a lot of frustration. So we got to provide, for your question, we got to provide a lot more support services. We got to use, this is where we can use technology an awful lot more to take away from you some of the things that just are totally overloading you, but also get rid of some of the things that don't make much of a difference anymore. I don't have any great answers to you on this, other than we keep continuing to, we work with our physicians on this all the time. We spend time with our physicians trying to figure out how do we make their life more comfortable, easier to work with. What should we take away from what they should not be doing? How do we make better use of the complements of staff around physicians? How do we develop a different care model so that and not saying have the same issue, by the way, but what is it you should not be doing that others could be doing? And what is it you should not be doing that technology can do?
Well, the answer.
And it's very circumstantial. I mean, it's very situational as well. You've got to look at every circumstance a little bit differently. That's what we're trying to do.
So why isn't Scribe being used as much? So technology is
You're talking
being
about scribes?
like having a person in the room with you. You talk to your patient. This is being scribed. That person will look in their basket. I've seen this work.
Well, we use them, guys, right? Yeah, we have scribes.
Okay.
Yeah.
That's a good answer. Thank you.
Yeah, we have scribes. Yeah.
Thank you.
But it's looking at the workload a little bit differently. Who does what? And how you provide the support staff around people. The same with the nursing. I mean, to have a nurse spending 60% of their time on non-patient care stuff is crazy.
So we can
Talk about burnout. And by the way, let me say something to be controversial. This is something that you got to deal with. There's burnout, don't get me wrong. But not everything that happens in life that is uncomfortable is burnout. We got to decide what's real burnout and what's just regular stuff you should just suck up and move on with. Okay? I mean, we got to teach resilience and grit. You got to build a high tolerance for discomfort if you want to be successful.
I used to see 43 patients a day using Epic in my country, and I never felt burned out until I came and I see 10 patients, and I feel very exhausted.
Right.
So it's not about the load of the patients we see, it's about all the requirements that are not contributing.
Understood. No, I understand. And one thing I just want to mention is that despite all of these things, by the way, we should feel unbelievably optimistic and positive. Because if you look over the last 50, 60 years and you see what we can do today that we couldn't even anticipate thinking about doing 50 years ago, it's extraordinary. It's an extraordinary success. So we're suffering from a crisis of success in many ways. And the other thing is, when you're in the business every day, you got to think about how fortunate people are who are in the business, because you get up every morning with the possibility to make life a little bit better for somebody else. Not anybody, most people in other businesses don't get a chance to do it to the degree we can. I tell staff all the time when I meet with them, in the morning when I have to do the orientation, there are people coming into our facilities right now, and every single one of them are coming in, whether it's outpatient, home, or ambulatory, whatever, are coming in because there is something that is hurting. Family-wise, individual-wise, some in dire circumstance, some in moderate circumstance. And because of what we do each and every day, many of them, most, will go home tonight better off. There are very few professions you can be in that gives you the satisfaction of knowing that you're doing that. You don't do it 100%. Some may go home a week from now. But we make a difference. We should be proud about that. That's why we're in the business. And to be able to do our business well, we've got to deal with the imperfections and some of the dysfunction, but at the same time, try to improve it. And big health systems have the ability to do this if they go about it doing it the right way. So we're very, very fortunate in many ways. And got big issues ahead of us, but the amount of great work that's going on every day is pretty extraordinary. and we shouldn't forget it. You know, sometimes you can have these discussions and you walk away thinking everything doesn't go well, but there are thousands of miracles occurring every single day. Lives are saved, babies are born, people living longer. You know, in our transplant program, we've done doubles and triples transplant on the same patient in the same day in the last couple of weeks. Who would have thought? 50 years ago, 20 years ago, you could do that? Who would have thought in the 1970s, if you had a cardiac issue, there was very little we could do for you? Today, you have a 95 blockage, we can come into the hospital, and all of that stuff will eventually be ambulatory. Come into the hospital, you put a stent in, you walk home, and you're fine. The benefits outstrip the negatives all the time, despite all the difficulties that we just talked about. So it's important to put it in keep perspective. Fix what is wrong, complain about that which annoys us, but keep our mind focused on that which is positive and good. We're in a good business.
Terrific note. Thank you. This is a gift. Thank you much.